So very good morning to you all. Hope you all are doing well. Today we are going to discuss, this will be the part one of the specialty certificate exam we call, the exam which was conducted this year in June 2023. And this is my lecture number 63 in my Mastering Endocrine and Diabetes lecture series, which is designed for all the endocrinology exams as well as for clinical practice. So let's start right away. So one of the first questions which was asked was the inheritance for von Gierke disease, which we all know is a glycogen storage disorder. So glucose 6-phosphatase deficiency, also it is called von Gierke disease, is an autosomal recessive disorder. So that was the answer, an autosomal recessive disorder. So it was the first glycogen storage disorder which had an identifiable enzyme defect, and hence it was designated as also GSD1. The defective enzymes involved in GSD1 are mainly active in the liver and the kidney. So I remember that this was also asked in one of the previous exams uh, for the action where it is acting on which organs, so liver and the kidney. Patient presents with manifestations related to hypoglycemia. It can manifest as early as 3 to 4 months of age. Diagnosis is confirmed by genetic testing. Treatment is focused on maintaining physiological glucose level. And again, I am repeating, it's an autosomal recessive disorder. The G6 phosphatase gene or G6PC is located on chromosome 17q21. So I'm specifically mentioning this because this was again one of the questions in the previous exams. This year it was asked about the inheritance, but von Gierke disease commonly appears as questions in the previous exams as well. And again, the chromosomal location important. It is 17q21. Next in line is the half-life of testosterone. So this time they had asked for the endogenous testosterone, and that's 1 to 3 hours. In the previous exam, several times they have also asked for the half-life of the exogenous testosterone preparation. So we should be knowing about that as well. Testogel, which is a transdermal testosterone, as well as the oral testosterone, has a half-life of 1.3 hours. It can vary somewhere between 10 minutes to 100 minutes. Nebido, which is the IM form, the long-acting one, half-life of 90 days, whereas the again IM form, the short-acting one of testosterone cypionate, is of 8 days. Again, I remember in the previous exams, they asked about Testogel. They've also asked about testosterone cypionate. Kallmann syndrome, again, an exam favorite. This year also it was asked. Cal1, they'd asked specifically because it was an anosmic patient in the question stem, and they'd asked for inheritance of this scenario. So it is X-linked recessive anosmic form of IHH, also classic Kallmann syndrome. It's typically causing the anosmic form of IHH, which includes the following specific gene, ANOS1, formerly called CAL1. It is an X-linked recessive form. This is located in XP22.3 region of X chromosome. This was the first gene found to be mutated in Kallmann syndrome and very commonly asked in the exams previously. Again, I have a detailed session on Kallmann syndrome, or you can always go to that lecture and see in details these inheritance as well as the different forms of genetic forms of Kallmann syndrome. So the another question which was asked was the most common side effect on the pan-retinal photocoagulation procedure for the eyes, and the night vision was in the options, and that's the answer. So we should be just aware of the common side effects of laser therapy. We already saw night vision is one of the side effects. It can also cause a reduction in the peripheral vision. Again, I remember this as the option in one of the previous exams. This time they had asked about the night vision. So the risk of vision loss for not receiving treatment is much higher than laser therapy. We should always keep in mind about these things. So some common and uncommon side effects. So uncommon wise, we have visual discomfort, glare, central vision loss, retinal detachment, choroidal detachment, macular decompensation, and intraocular pressure problems. So that's very, very uncommon to occur. But we should always remember for exams, especially reduction in the peripheral vision, as is the amount of light you can see is coming out of the corner of your eyes, or it can also affect the night vision, which was the answer in our question step. So A case scenario and an image given suggestive of pre-proliferative diabetic retinopathy. Again, if you have gone to my session of diabetic retinopathy in my lecture series, it's quite detailed how to identify if it is pre-proliferative, proliferative maculopathy, and what stages are referable and when we need to do the referral and what is the duration of the referral as well. So they had asked in this exam question about pre-proliferative diabetic retinopathy. There was also M1 or macular involvement, and they had asked when should be the next visit. The correct answer is routine referral. It is a referable maculopathy. So this is the chart from the Oxford Handbook. It's there in my lecture series as well. Immediate referral we need to do for rubeosis iridis, neovascular glaucoma, vitreous hemorrhage, advanced retinopathy with retinal detachment. Urgent referral, which is less than 2 weeks, we need to do for R3 proliferative retinopathy, as untreated PDR carries a risk of almost 40% in less than 2 years for blindness, and laser treatment will considerably reduce this risk. Routine referral, which is less than 13 weeks, approximately 3 months, is R2 and the pre-proliferative changes as our exam question patient, and M1, which is referable maculopathology. They're asked for the half-life of I-131. The correct answer is 8 days. We should know for both oral I-123 and IRL-1 for I-131. Oral I-131, as in the exam, has a half-life of 8 days, is used for whole body scan, 5 to 10 days post therapeutic I-131. On the other hand, oral I-123 has a clinically useful half-life of 13 hours and can be used in routine diagnostic scans or whole body scan at 24 to 48 hours with high quality images, which we can get at a lower radiation dose. And it also provides quantitative information in imaging residual thyroid and functioning metastasis after thyroidectomy in thyroid cancer. Moving forward, discussion, I think they have asked consecutively in the last two exams, the ratio of T4 is to T3. The correct answer closest was 15:1. In humans, a normal thyroid gland produces 85 micrograms of T4 and 6.5 micrograms of T3 daily. Thus, the ratio of T4 to T3 will be, for a normal thyroid gland secretion, will be around 13:1. The closest in the answer was 15:1 in the exam question. Hypothyroid patient, pregnant patient with on levothyroxine 125 micrograms. Sorry, it's not milligrams, it's microgram. Now pregnant, immediately came for blood test. TSH of 0.35 MIU per L. What should be done about the dose? Well, the TSH looks in the trimester specific range. It's already in range, so keep the same dose. We should be aware of the trimester specific ranges: 0.1 to 2.5 for the first trimester, 0.2 to 3 for the second, and 0.3 to 3 for the third. So more or less to know that we should try to aim to keep the TSH below 2.5 up to the end of the first trimester, and then subsequent trimesters we should aim to keep it at least less than 3 MIU per liter. Hypoglycemia, very commonly asked as question scenarios. I have done detailed sessions for hypoglycemia. There is a full lecture series on hypoglycemia, its management, and according to guidelines, the different pathways for mild, moderate, and severe. And two questions have come in this exam as well. Patient is fully conscious, diabetic patient, hypoglycemic. What is the best thing to give to this patient? The best option, best answer from the options provided was 150 to 200 ml of fruit juice. So this is a mild pathway, mild hypoglycemia pathway, adults conscious, oriented, able to swallow. Always check ABCDE. Stop IV insulin infusion if running. Give 15 to 20 gram of quick acting carbohydrates such as 5 to 7 dextrosol tablets or 4 to 5 lift glucotabs or 150 to 200 ml of pure fruit juice, which was our question, which was the answer in the question. Test blood glucose level after 10 to 15 minutes, and it's still less than 4 millimole per liter. Repeat the treatment as above up to 3 times. If still hypoglycemic, we should definitely go to the severe pathway, which is giving an IV dextrose or an iron glucose. So always make sure check ABCDE in all scenarios, and if the patient is on IV insulin infusion for any reason, that should be stopped first. Hypoglycemia scenario, again, patient this time was confused but not unconscious. Out of the options given, best answer was glucogen. So again, in the moderate pathway here, the patient is conscious and able to swallow, but he's confused, okay, disoriented or aggressive. Again, check ABCD. stop IV insulin infusion if running for any reason. If capable and cooperative, treat as for mild hypoglycemia. But in our patient, in this question scenario, patient was confused, not capable and cooperative, can swallow a glucogel. So 2 tubes of glucogel was given, of 40% glucogel, again, very, very important, squeezed into the mouth between teeth and the gums. Test blood glucose level after 10 to 15 minutes. And if still less than 4 millimole per liter, repeat as above. This can be done up to 3 times. If still hypoglycemia, consider IM glucagon or IV dextrose as per the CFR. Now, all these quantities, which is mentioned like 40% or 150 to 200 ml for that matter in that, or for example, 4 to 5 glucotabs, 5 to 7 dextrosol tabs. These are very, very important to remember by heart because they tend to confuse in the options provided in that. Again, this is all as per the guidelines. I have done a detailed lecture on this, which is based on the JBDS guidelines or the Joint British Diabetic Society guidelines. You can see all the mild, moderate, and the severe pathway. Now, endoscopic preparation in a patient with Addison's disease or primary adrenaline deficiency insufficiency. This patient was on steroids. What is the pre-procedural preparation? Again, we should know what all options are there and what all things can appear in the exam. The candidates didn't remember accurately what were the options provided, but the closest will be 50 milligram IM hydrocortisone, or the other option will be hydrocortisone 100 mg IV on induction. So I'll just go through all the things which is there as per the guidelines, which is there on the Addison Society website. And I think we should be aware of this. Candidates, when they recall, they may not remember exactly the options, but I will tell you as per the guidelines so that you remember for all your patient scenarios in the future. So this is basically the recommendation of the guidelines for primary as well as for secondary and tertiary adrenal insufficiency. So if the patient was to undergo an endoscopy, like our patient in the question, or a surgery under anesthesia, whether it is general or regional, like a joint replacement, or for example, an IVF or an egg extraction, the recommendation for the pre-operative preparation is as follows. So we should give hydrocortisone 100 mg IV on induction, followed by a continuous infusion of hydrocortisone at the rate of 200 milligram per 24 hours. Okay, or we can give 50 mg of IM 6 hourly hydrocortisone for a more sustained duration, as was the possible answer in this question step. And post-operatively, of course, we know we tend to continue the hydrocortisone infusion while the patient is still nil by mouth, or if the patient has post-operative vomiting. Or we can simply switch to again hydrocortisone 50 milligram IM 6 hourly. We can resume the oral glucocorticoid dose at pre-surgical levels if recovery is uncomplicated. Simple. Minor procedure under local anesthetic, any minor procedure, take an extra dose 60 minutes ahead of the procedure. Post procedure, take an extra dose 60 minutes after procedure. Bowel preparation, which requires laxative or enema, has been asked in the previous exam. Bowel preparation should be done under hospital clinical supervision. Consider IV fluids and injected glucocorticoid, again here 50 milligram hydrocortisone IM or IV 6 hourly during preparation, especially for those who are fludrocortisone or vasopressin dependent patients. Again, hydrocortisone 100 milligram IV or IM at the start of the procedure again. So apart from this preparation, also 100 milligram IV given at the start of the procedure. So very important for bowel procedures requiring laxatives and enema. Post-procedure, resume oral double hydrocortisone dose for 40 hours. Now, if it is a labor or a vaginal delivery, and active labor here is defined as cervical dilatation more than 4 centimeters, hydrocortisone 100 milligram IV at the onset of the labor, followed by infusion of hydrocortisone 200 milligram for 24 hours. Or hydrocortisone 100 mg IM followed by 50 mg every 6 hours IM. Again, question has been asked in the previous exams as regards the vaginal delivery. And post-delivery, resume oral double hydrocortisone doses for 48 hours. So very clear-cut guidelines from the Addison. Another Addison's case scenario for patient for dental extraction was asked, and they had asked for the pre-procedural preparation. The closest was 100 mg of hydrocortisone IM before anesthesia. So there are specific guidelines again from the Addison disease org, and I have mentioned this for specifically for dental procedures. So if it's a major dental surgery, so our patient in the question stem was to undergo a dental extraction under a local or a general anesthetic. In this scenario, he will need 100 mg hydrocortisone IM just before anesthesia, and post procedure he will need double dose oral medication for 24 hours and then return to the normal. Basically, double dose hydrocortisone. Dental surgery, if it is root canal work under local anesthetic only, then we are doubling the oral dose. We can go up to 20 mg hydrocortisone 1 hour prior to surgery. And we maintain the double the oral dose of hydrocortisone for at least 24 hours, then return to the normal dose. If it is a minor dental procedure only, like replacing a filling, scaling, and polishing, then we take an extra oral dose 60 minutes ahead of the procedure, and then we take an extra dose where the hypoadrenal symptoms can occur after the procedure, and then we can just go back to the normal dose. So again, all these are very important guidelines when we talk about steroid-dependent patients requiring steroid cover post procedure. There was a question scenario asked about the beta cells of the pancreas. They are inhibited by what particular hormone? And the options for glucagon, somatostatin, GIP. The correct answer here is somatostatin. I'll just quickly take you through the glucose hemostasis pathway. Here we can see the paracrine interactions between the islet cells. We can clearly see that the insulin, which is secreted by the beta cells, act as the prime hormone of glucose homeostasis, and this inhibits the glucagon secretion by the alpha cells, whereas the glucagon activates the insulin. So you can clearly see the glucagon activating the insulin and somatostatin secretion as well. Okay. And the somatostatin, which is basically secreted by the delta cells, and the ghrelin, which is secreted by the epsilon cells, they inhibit the insulin. So basically, it is the somatostatin which inhibits the beta cells, and that was the answer in the question step. Let's move forward. There was also a question where a pregnant diabetic lady was asking for the risk of congenital malformation. Her HbA1c was high at 75 millimole per mole. So if you look at the correct answer, the closest answer will be 4% in this scenario. Now, looking at the data regarding this, so cardiac and neural tube defects occur during the first 40 days, stressing the importance of optimizing glycemic control well before conception. The risk of having an infant with a major congenital abnormality is comparable for both type 1 and type 2. So it doesn't matter whether it's type 1 diabetes or type 2 diabetes. So it doesn't matter whether this lady was type 1 or type 2 diabetes. Okay, it is 4 to 5%. And more than twice that of the background maternity population. So for a background maternity population without diabetes, it will be 1 to 2%. But a woman with diabetes has the risk of congenital malformations around 4 to 5%. And the contributions for hypoglycemia, and metal obesity definitely are well recognized. This is alterations in the O2 free radicals, myoinositol, arachidonic acid, and zinc metabolism have also been implicated. Stillbirths, 14 per 1,000 births with an increased risk if poor glycemic control and infants were large or small for gestation. Neonatal death, 10 per 1,000 births in mothers with type 1 diabetes and type 2 diabetes. So we should always be aware of the serious adverse pregnancy outcomes associated with diabetes. The other question scenario, Turner syndrome is exam favorite. This time they're asked for karyotype of Turner syndrome associated with increased risk of gonadoblastoma. The correct answer is 46XY. This has an increased risk of gonadoblastoma. So the treatment option will be for this will be recommend gonadectomy. So there is a correlation of the karyotype with the phenotype. 45X, which is the majority, which is 50%, is the most severe phenotype. This has the highest incidence of cardiac and renal abnormalities. We have 46XI. This has increased prevalence of thyroiditis, IBD, and deafness. 45X and 46XX, less severe phenotype, fewer comorbidities, spontaneous puberty and menses in up to 40%. 46XR, spontaneous menses in 33%, congenital anomalies, uncommon, cognitive dysfunction in those with small ring chromosome. And then we have the exam question, which is 45X or 46XY, which is around 6%, has an increased risk of gonadoblastoma, and we recommend gonadectomy. Again, in these, the top two are also very important, has been asked subsequently in the previous exams, the 45X and the 46XI. Remember about the increased prevalence of thyroiditis with the 46XI has been asked previously, as well as deafness. And of course, we are all aware of the 45X, which is the 50% karyotype, most severe phenotype in this and has the highest incidence of cardiac and renal. Now, there were several DVLA questions. I'm going to go through the DVLA guidelines in this so that it will help support answering any questions which will occur for the DVLA and the diabetes. So there were some DVLA questions for insulin-treated diabetes and driving. So we look at that first. Type 1 diabetes, which is insulin-treated diabetes patient, can drive and need to inform DVLA. We know that. And there was an advice as regards blood sugar testing. When should you test your blood sugar? So correct answer, as per the options provided, will be should check the glucose less than 2 hours before starting the journey, and then every 2 hours after driving has started, independent whether the patient is wearing a CGM or not, which is a continuous glucose monitor. So this is extremely important. Now there are various points which I'm going to go through in the next slide, which are extremely important to note for the exam perspective, as far as the answering all the DVLA questions. So basically, that's the end of my free view. And if you like to hear this full session, please subscribe to my lecture series. So in this particular part, I have gone through up to 15 questions with you all for the free view. And the full session is of around 40 questions, 40 recalls from the previous exam. I am planning to do 4 parts for this, which will include up to 160 recalls from the previous exam, which was of 200 questions. For accessing this particular free full view video as well of 40 questions, including the DVLA guidelines, of course, and all the remaining 25 questions, please subscribe to my lecture series, which is Mastering Endocrinology and Diabetes by Dr. Mazhar Dalvi. And all the paid subscribers will be given lifetime access to all my existing 63 lectures, which are already on the YouTube channel. So this is the lecture number 63, and there are many more to come. And the good thing is that with one-time subscription fee, you'll get lifetime access for all my existing lectures, plus all my forthcoming lectures. For the full subscription details, please email me on mazirules@gmail.com, or you can WhatsApp me on 00971557434794, and the same number is on Telegram. So thank you so much again. As I mentioned, this is an extremely useful lecture series for all the exams as well as for clinical practice. So thank you for listening, and I'll be coming up with more and more lectures. Thank you.